Hello again and welcome back. Today I'm going to be talking about how to identify malignancies in oral radiology, and specifically I'm going to be introducing ill-defined radiolucencies of the jaws. So if you haven't watched already, look for the Principles of Interpretation lecture, which I'm going to record. I haven't recorded that yet, but that does go through the basics of distinguishing between benign and malignant type of lesions in the jaws. And this one I'll go through, like I said, mostly malignancies, but also we need to talk about acute osteomyelitis, which can appear just like an ill-defined radiolucency in the jaw, so that can be very difficult to distinguish from a malignancy. Here's our outline. As I said, that's what we're going to start with is acute osteomyelitis, which can look just like a malignancy, and then we'll talk about the general properties of malignancies, and then we'll get more into specifics, so squamous cell carcinoma, fibrosarcoma, and as you see, all of these other ones. There are a lot more malignancies than this, but I'm going through the most common ones. As we know, squamous cell carcinoma is by far the most common malignancy of the oral cavity, so of course we have to start with that. And a lot of times it's difficult to distinguish what type of malignancy it is, and you won't know until you do the histopathology. And so mainly this is to help you distinguish when you should start thinking that something might be a malignancy, when it should raise red flags in your head, and definitely recommend prompt follow-up by the patient. Refer them to a surgeon if you're not comfortable doing a biopsy, but get that biopsy and the final diagnosis because you're worried that this could be life-threatening situation. All right, as promised, acute osteomyelitis here. So what do we see that distinguishes this? What do you see in general? We see some radiolucencies, right? Are these well-defined like some of those other cysts and benign tumors that we've noted? No, this is kind of the definition of ill-defined, where it has a blending border, where you're not really sure where the border started, where the lesion started and where it ends. In some of these areas, this looks like a well-defined lesion, but these are the ones we're talking about where it has a blended border. This one where it's somewhat irregular. So in a lot of cases, you will lump something with an irregular border along with a malignant diagnosis, particularly when it's a radiolucency like this. And so I see some signs of malignancy, other signs I don't see. I'm going to focus a lot on the PDL spaces and see how the PDL spaces are intact and uniform, maybe a little bit widened here, but uniform PDL widening. And I see that everywhere. And so that may be one hint that this is not a malignancy, that this is an acute osteomyelitis. But when you see that ill-defined nature of a radiolucency that looks like it's invading into the bone, it is something that should raise those red flags in your head to start thinking this is a possible malignancy. And in fact, I always tell the story of one case that I got. It was a cone beam case, but it looked like a malignancy where it was just really destroying the bone, had an ill-defined blended border, starting to seep around the teeth. And on the differential, I had malignancy first because we wanted to be wary of that. Of course, they did biopsy and it came back just inflammatory cells. This was a surgeon treating it. And he treated with IV antibiotics, threw everything he could at it, and it would not let up. So ultimately had to treat it as if it were a malignancy. So pretty rare case, but you can get a very aggressive acute osteomyelitis that starts behaving like a malignancy. And in that case I was talking about, the surgeon had to go in and basically resect the mandible. Like I said, he treated it as if it were a malignancy because nothing else would slow it down. So pretty rare. In most cases of osteomyelitis, you're going to see a mixture of acute and chronic, where you have the mix of radiopaque, radiolucent lesions. Remember, sequestra is the hallmark of osteomyelitis. So if you see sequestrum, if you see periosteoreaction, those are certain things that should lead you toward osteomyelitis first on the differential. And so this is just a case of a very aggressive acute osteomyelitis. So now general properties of malignancies, clinical properties. This yellow highlights the typical location of malignancies. We know the tonsillar pillars, the retromolar region they call this, behind the molars, especially in the mandible, but anywhere going up along those tonsillar pillars, the side of the tongue, so the lateral border of the tongue, and the floor of mouth. So as we know, those are the most common, areas that patients get malignancies. These are typically soft tissue tumors, but because we're talking about the most common malignancy of the oral cavity is going to be squamous cell carcinoma, and that is a soft tissue tumor. And so radiographically, what are we looking at? We're looking at when it invades into bone. There are cases where you get malignancies that arise within the bone. We call that a central lesion if it arises from within bone. And so what distinguishes these from benign lesions is malignancies, of course, metastasize to lymph nodes or distant sites, and that's what makes it malignant, what makes it potentially deadly. Malignancies grow relatively fast compared to other benign lesions that we've talked about, benign cysts or tumors. And so what that does is it destroys bone around the teeth, leaving teeth loosened over a short period of time. The teeth floating in air, maybe you've heard that appearance as a sign of malignancy, not always, but it speaks to the rapid growing property of malignancy to destroy bone around teeth and leave them floating in air. Exposure of underlying bone, so sometimes if you get a soft tissue lesion that's eaten through the soft tissues, you can get exposure of bone. Sensory and motor neural deficits. Why is that different from benign lesions? If you have a cyst or a benign tumor, those tend to grow slowly, and so they push against nerve canals. Even the mandibular canal can be very grossly displaced, and the patient doesn't get symptoms. Contrast that with malignancy here, and malignancy tends to invade into neural spaces, and it tends to interact with those nerves, and that causes pain or paresthesia. So that is not a clear-cut indicator, but a strong indicator that someone has a malignancy. All right, pain and rapid swelling when you've ruled out any dental cause, you're not your typical swelling or infection case, you should be wary of a malignancy. More common in males, more common the older people get, but obviously that's not exclusive. So take that with a grain of salt. All right, we highlighted the areas, the yellow areas here as common areas to get squamous cell carcinoma, so carcinoma specifically. Sarcomas, however, they can arise within the bone, so within the mandible, posterior of both jaws. Metastatic tumors can really arise anywhere throughout the body, and so you may see that all profusely throughout the jaws, but it is common to occur in the posterior mandible or the maxilla. In some cases, we'll show you cases of where certain malignancies tend to metastasize in the apices, especially of developing teeth. And so I've showed you examples of ill-defined lesions, that border that looks like it's blended, where you're not really sure where it starts or where it ends. But then also you want to think of this ragged, I'll call it a moth-eaten border. Here's a picture of a moth-eaten coat, if you're not sure what moth-eaten means, where you leave little remnants of trabeculae behind, where it really is ragged. That is a sign that it's something, even if you wouldn't describe that as ill-defined, you want to think of lesions that are typically ill-defined, like malignancy, when you get that ragged, destructive border. We've mentioned this point right here. Tends to follow the path of least resistance. I talked about it invading canals, but it tends to destroy cortices around these things. So it tends to eat into the cortices of the lamina dura surrounding the teeth, the cortices of canals, and tends to just destroy those. Whereas benign things tend to displace them and maintain cortices. There are some rare exceptions to this last point here. Some malignancies do cause periosteal reaction, but for the most part, when you see periosteal reaction, what's the first thing that should come to mind? First thing you should think is probably osteomyelitis, because that's the much more common thing that causes periosteal reaction. But we'll talk about some of the exceptions to that. All right, these are little graphics showing different types of how malignancies spread, that ill-defined nature, maybe leaving behind little sparse trabeculae intact. This one hasn't shown it interact with the teeth yet, but down here I like this image because I teach my students all the time. I really have them focus on the PDL spaces when you're trying to distinguish between malignancy or non-malignancy. And if it tends to eat the lamina dura away and leave maybe a similar to trabeculae behind appearance, where it was just destroyed that lamina dura, leaving kind of a halo around the apices, around the roots of teeth, especially if it's somewhat of an irregular PDL space widening, then that's a sign of malignancy. All right, this shows a maxillary lesion as it's eaten through the cortex of the floor of the sinus, and then the soft tissue portion of the lesion extends into the sinus. But you also maintain that kind of ragged trabeculae left behind appearance. In D, this shows in some cases malignancies tend to accumulate at the apices, especially of developing teeth. I would think of leukemia It's a primary one if it's a young patient and they have developing teeth, but also Langerhans, lymphoma, they can do that. They can develop in around the apices of developing teeth. All right, figure E here shows different effects on the cortex. Sometimes it just breaches the cortex with no real periosteal reaction. And in fact, in our carcinomas, in our common malignancies, this is what's going to happen. It just tends to eat through bone. And sometimes you get this onion skin reaction. So I said, you see that type of reaction, specifically, you should be thinking osteomyelitis. But in some cases, Ewing sarcoma, Langerhans, and some of the other rare malignancies can cause that onion skin periosteal reaction. And so if you see the onion skin, don't completely rule out malignancy, especially if it's just purely destructive in the bone, leaving these other signs of malignancies, those sparse trabeculae, remnants of trabeculae that are left behind, irregular pattern. This shows what's called a Codman triangle, which it could indicate infection, but in some cases, similar to the onion skin periosteal reaction, it can be an indicator of a malignancy. And then here's a great sign. If you see this on a board exam or in a patient, that's a kind of a slam dunk, because the first thing you should think when you see the sunray appearance is osteosarcoma. Osteosarcoma is the one that's known to do that. The other one might be chondrosarcoma, which is going to appear very similar to osteosarcoma. It just appears in very certain locations. And then here I've already stated this, but the teeth floating in space appearance, especially when you see those other signs of the ill-defined or ragged border invading the PDL space of surrounding teeth. Because malignancies just like to destroy bone, they tend to leave teeth around alone. If they do resorb roots of teeth, which they can, it will usually resorb it from the periphery and leave spike-shaped roots of teeth. And how does that differ? A little thought question for you. How does that differ from a benign tumor or a cyst when it resorbs roots of teeth? Because those are even more likely to resorb roots, specifically benign tumors, ameloblastoma. Dentigerous cysts like to do it as far as cysts. OKC can do it. But when a benign tumor or cyst resorbs teeth, it follows that straight pattern, that slow growth of the benign tumor, slow and straight, maybe, a gentle curve across. And so it doesn't do that spiked root shape, but a benign thing does more of a flat, straight line resorption across the roots of the teeth. Okay, real quick on this slide here, just imaging modalities for detecting malignancy. You should know that intraoral has the best resolution of all the different modalities we use. Panoramic is a great quick overview. It shows certain structures, but not all. Great view of the maxillary sinus floors and borders, so you can assess those and make sure that none of those borders have eroded from some potential lesion. CBCT, benefit of this is the 3D analysis, better determine the extent of the tumor. To some degree, you can see the soft tissue extent, but if you really need to see soft tissue extent, you're going to want to go with one of the medical modalities. Medical CT or multi-slice detector CT can show soft tissue extent better than cone beam CT, and MRI is the choice for soft tissue. It really delineates various soft tissue from others, and so it can show perineural spread, involvement of lymph nodes. What I didn't mention here is PET. So positron emission tomography. So that is a nuclear type of imaging, which can be overlaid with medical CT. So they'll do PET CT scan, and that shows metabolic activity. That's going to pick up wherever there's a higher amount of metabolic activity. The brain is going to kind of light up. But what do we know about malignant tumors? And to some degree, benign tumors can do this, but malignant tumors especially, they're turning over. They have a high metabolic rate. And so those really light up on the PET CT scan. And so those are things that will be done in the medical world, analyzed by a physician radiologist. All right, we said the first one we're going to talk about is this, squamous cell carcinoma, as it's the most common malignancy of the oral cavity. Typically going to be a soft tissue tumor, but radiographically, we're worried about it because it can extend into the bone. And so this is likely a soft tissue tumor. And they do tend to arise in extraction sites. So if you have a non-healing extraction site, be wary of this. So very ill-defined, blended border, perfect candidate for a potential malignancy. Really destroyed the anterior maxilla here. This one has more of a well-defined, but that ragged border. We have a little spindle of trabeculation left, kind of a ragged border. So could it be an osteomyelitis? Sure, especially with these sclerotic borders, where it looks kind of smooth and sclerotic. You might be thinking more infection. But just the ill-defined nature of this and the way it's so destructive, starting to leave that tooth floating in air appearance, be worried about a malignancy. This shows one, which I'd like to blow that up if I can. Okay, what is the big worrisome thing in the panoramic radiograph here? Look for the anatomical structures. Hopefully you've watched my lecture on interpreting panoramic radiographs, and you recognize all these different anatomical structures, especially the sinus floor and the zygomatic process of the maxilla. And you notice that one of those is missing here. There's no sinus floor. The maxillary bone over here is completely missing. You don't really see where it starts or stops. We've got this tooth floating in air here. The arrow is pointing to a little extent of the soft tissue tumor. So if you looked in this patient's mouth, it would be pretty apparent that something gnarly was going on. And so this is some type of soft tissue tumor that's completely destroyed the bone here. When you see that, be worried about malignancy. Have that on your radar, on your differential. This shows a cone beam CT. These are all three of the same case, just an axial slice. So the horizontal slice through the mandible, as we see, the posterior part of the mandibular ramus here. It looks well defined, but it does have that ragged border. So have that raise alarms in your head that this could be malignancy. Same thing in the coronal plane, and then in the panoramic radiograph. Yeah, I would argue this is well defined, but the way it's so ragged, leaving behind those little spindles of trabeculation. Contrast that with your typical cyst and benign tumor that should have a smooth corticated border on it. An exception to that is a cyst or benign tumor. They can become infected, and that infection, those infective byproducts can resorb the bone around the lesion and maybe leave a ragged or ill-defined border. Usually it's not all the way around the lesion like this. And so you really should start thinking malignancy when you see that much of the lesion that has ill-defined borders or ragged borders. Okay, here we have a case. In both of these, A and B, it may be tough to distinguish from periodontitis. But what do you look for when you're looking for osteomyelitis, which I stated earlier, is typically in osteomyelitis you have some degree of chronicity, some degree where the bone has laid down more bone. We know that periodontitis is typically a chronic disease, so if they have a periodontal lesion, usually have that smooth sclerotic border around it. These to some degree look well defined, but then you look closely at the border and there is this narrow area of an ill-defined border. Little bits of trabeculation where they're just starting to fade. And so you don't see that sclerosis around it. This one really doesn't look like a typical acute periodontal lesion. It's just too destructive and round to be something like that. And so, yeah, they can be difficult to distinguish from just a periodontitis, an acute localized periodontitis, but do have it on your radar, especially when you see something this destructive and something that lacks those smooth sclerotic borders. This one, though, I think is pretty clear cut, where the first thing on your differential for C and D looks like the same case here, should be a malignancy. And why is that? Why not just infection? Well, if it's infection, where do you commonly get infection? Does it look like a typical periodontal or periapical infection? No, it doesn't really look like it's coming from the root of any of these teeth. Does it look like a periodontal infection? No, it doesn't really look like it's coming from the periodontal space either. This looks like it's arising from within bone, and then it has somewhat of an ill-defined blended border. It's starting to invade into marrow spaces, and then what's the key sign here around the roots of the teeth? See that little radiolucent haloing? We said malignancies really like to follow that path of least resistance. They extend into the apices or into the PDL spaces of teeth and destroy the lamina dura around it. Somewhat of an irregular PDL space widening appearance. But that is a strong indicator of malignancy, even over a potential acute osteomyelitis. Some more cases. This is similar to cases over here where it couldn't just be periodontal disease, a very severe periodontal disease, yeah. But look for signs of infection. I don't see that smooth sclerotic border. I see teeth floating in air. Doesn't look like your typical periodontal disease, and you're going to be really wary of a malignancy. That's not to say that there isn't concurrent periodontal disease. In fact, they've got bone loss all around here. And this is a good example of that. Large triangle of calculus here. Obvious periodontal lesion, looks like a perioendo lesion. It's involved the apices of the teeth. This one does have a smooth border. That's what I'm talking about with looking for infection, seeing some degree of a smooth sclerotic border around it. But then over here, we have tooth floating in air. We have more of an ill-defined, no sclerotic border around it. And that's really worrisome for a malignancy. All right, in C, we have somewhat irregular widening of this canal. Now, I don't have right here, but you want to compare maybe in your mind's eye to a well-defined benign type of lesion that expands the canal. And it has more smooth, maybe rolling borders. Hemangioma is known to create a serpentine shape to the inferior alveolar canal, but typically it maintains nice, smoothly corticated borders. This, in some areas, it looks corticated, but in most of it, it looks like that cortex is destroyed, and it leaves behind this irregular pattern. And so that's a sign of perineural spread of a malignancy. This one, a little tricky. So here we have a cone beam CT, looks like a sagittal slice. So like it's sliced vertically and like you're looking from the side. Parts of it do look well defined and somewhat smooth, but I would argue that part of this is irregular. Down here, less corticated, still somewhat well defined, but maybe you're starting to see some of the trabecular pattern, where you get individual spindles of trabeculation left behind, which I said was a sign of malignancy. And then the giveaway here is this black arrow. We see proximal up the canal along the superior border, so closer to the origin of that canal, is this irregular, still well defined, but it's an irregular erosion along the superior border. And this is perineural spread, showing that, okay, what likes to do perineural spread? Malignancies. And so bad signs in this case, even though some of it look well defined and might make you first start thinking it's a benign thing, look for these other signs. Look for that ragged border. Look how destructive it is. If this were some large cyst, you'd expect it to be more kind of sac-shaped and just have that nice smooth cortex around it. This is an image I just showed you, just blown up now, showing that ragged border, those trabeculation left behind, moth-eaten appearance you could call this. All these things should lead you toward thinking malignancy. And so what's the differential diagnosis for squamous cell carcinoma? All those were cases of squamous cell carcinoma, by the way. In most cases, probably 99% of cases of squamous cell carcinoma, it arises from the soft tissue, then erodes into the bone. I think next we're going to get into that it can arise from little epithelial remnants, usually of dental tissues, if it arises from within the bone, but that's a lot more rare. Okay, so from the soft tissue into bone, osteomyelitis. This is pretty rare. Look, if you see something you're pretty sure are sequestra, especially when it has that chronic appearance, where you have those really dense sequestrations, that's more your osteomyelitis, more your chronic osteomyelitis. What we're describing here is squamous cell carcinoma may have that ragged appearance, and in some cases, those spindles of trabeculation left behind might look like sequestra. But in my mind, it's pretty easy to distinguish a real osteomyelitis sequestrum from what we're talking about here. More invasive, destructive. Whenever something just behaves really aggressively and destructive, you want to start thinking malignancy. And then this is a key here. No periosteal bone reaction in squamous cell carcinoma. So your typical carcinoma or your typical malignancy of the mouth is not going to cause that periosteal bone reaction. Osteoradionecrosis, that would be similar to osteomyelitis, but you're going to just compare to the history. What's osteoradionecrosis? The patient has a history of radiation therapy, something with a very high dose of radiation. There is no amount of diagnostic radiation that's going to cause osteoradionecrosis, especially in the dental world, but even when we're talking about CTs, MRI has no ionizing radiation. And so it's a history of a previous malignancy that was treated with radiation therapy. Those are very high doses of radiation that can potentially cause new malignancies. But the trade-off, of course, is they need to treat the malignancy at hand. And radiation sometimes is a very good option for destroying that current malignancy. Okay, as promised here, I said in some cases, maybe 1%, I don't know the exact number, but a small number of cases of squamous cell carcinoma that could arise within bone. Typically remnants of a odontogenic epithelium. So as we see here, it's pretty close to the odontogenic region. And so there can be epithelial cells left behind that can turn into a squamous cell carcinoma. But other than arising from within the bone, everything else is the same as what we just talked about with squamous cell carcinoma, more common in the mandible than the maxilla, tooth-bearing regions. Ragged borders. This looks somewhat smooth and round and well-defined, but if you look closely, it has those little ragged moth-eaten borders. And so that's a bad sign. In rare cases, squamous cell carcinoma can arise within a cyst. This is really rare. Patients got to hit the unlucky lottery to get something like this. But cysts have epithelial cells. They can, in some cases, degenerate into a malignancy. So what are the properties we see here? I would call this irregular, moth-eaten. Looks like maybe a dentigerous cyst, or it could be an OKC, another type of cystic type of lesion. But it's really lost that corticated border around here. So either very severely secondarily infected, or this might be turning into a malignancy. I already showed you one example of a panoramic radiograph where the sinus borders went missing, and I said that should be, red flag in your mind. Sinus border missing on one side, not the other. You have to think, what's destroying that? Is there some well-defined, smooth-bordered corticated lesion doing it? Or is it ill-defined, or in this case, more ragged? Although if you look very closely at the bone here, I think the malignancy has destroyed a lot of the bone, eaten into the marrow space here. So I would call this ill-defined. Definitely I would call it ragged. I would call this teeth floating in air, but does it look like your typical periodontitis? Hopefully you recognize it does not. Here's a cone beam CT of the same case. We really have the teeth floating in air. This looks so much like a case that I saw where the dentist did not diagnose it because they didn't know how to diagnose cone beam CT. And it was really sad because it should have been treated a lot earlier in the patient's life, but within just a couple of months, it had expanded all the way up into the patient's orbit. Very poor treatment, I think. It just goes to show that was a case that really shows how necessary it is to thoroughly investigate all your radiographs, and especially in cone beam CT where you have that 3D view, where you see so many more structures than you do even in panel. Although I pointed out all the different anatomical structures that are very clear in a panoramic radiograph, cone beam CT probably 10 times the number of structures. You're looking now at the skull base. The floor of the skull has so many foramina, all the way back into the nasal cavity, all the paranasal sinuses, not just the floor and posterior border of the maxillary sinus. But there's so much more responsibility that comes with that with 3D imaging. Anyway, here's another case. Here we see the floor of the sinus, but now we kind of have a floor of sinus floating in air. Not really a known sign, but we have an ill-defined destructive of the entire maxilla here. The posterior border of the sinus is destroyed. Where's my favorite anatomical structure on that side? And if you don't know what my favorite anatomical structure is, go back to my anatomy lectures. Something definitely to recognize. Zygomatic process of the maxilla. Why is that my favorite? Well, if you can distinguish that, you can distinguish it from the floors of the maxillary sinuses and recognize when one or the other is missing, which could be a sign, as is in this case, that you have a malignancy. So these are squamous cell carcinoma arising in the maxillary sinuses, certain risk factors, but I would say be able to identify these radiographically. All right, fibrosarcoma, if you look at this panoramic radiograph, Basically, it looks really similar to what we just showed you with squamous cell carcinoma arising in the sinus. Nothing necessarily radiographically jumps out to me and says this is a fibrosarcoma and not some carcinoma that arose in the sinus. We have your ill-defined borders, just very destructive. If they had teeth here, maybe the bone's been destroyed so much that they're just falling out at this point, but you might have that tooth floating in air appearance. Fibrosarcoma, a little bit younger, this peak prevalence compared to your carcinomas, your squamous cell carcinoma. So peaks in the 4th decade, meaning in the 30s, if you didn't get that. An enlarging mass can cause pain, as you would expect with malignancy. Typically what I do here is on these slides, I'll highlight in yellow text things that stand out from your typical malignancy. So we went through signs of typical malignancy, and we already said pain, paresthesia, that's common with malignancy. And so yellow is things that I think are more specific to whatever lesion we're looking at the moment. So growing along the bone and through the marrow space. All right, but as I said, there's nothing super distinguishing about this radiographically from carcinoma, from multiple other types of malignancy. So mainly be able to recognize the really destructive pattern of this and the ill-defined nature. What else is it destroyed? Floor of the sinus I mentioned. My favorite structure, again, zygomatic process of the maxilla. In fact, you don't see the zygoma at all. Here you see the zygoma and the zygomatic arch extending back here. That's all destroyed here. So that entire side of the face has just been completely destroyed. The palate is gone on that side. All right, radiographically, the appearance very similar to other central malignancies. So you're going to have on your differential, is it a metastasis? Do they have some other prior known malignancy? Myeloma, intraosseous carcinoma, or basically any type of lesion. Fibrosarcoma, other sarcomas, especially osteosarcoma, chondrosarcoma, those can be like more of an enlarging bone, where it really tends to enlarge and grow the bone outward. So sarcomas can do that rather than just being completely destructive. But radiographically, the fibrosarcoma at least look just destructive like the other ones. All right, let's talk a little bit about metastatic tumors. And what's a good, I'll give you this great acronym for memorizing the most common primary malignancies to metastasize to the jaws. And that's down here, BLT kosher pickle, BLT-KP. So breast, lung. As you look at the percentages here, we've already covered almost half. Thyroid, kidneys actually higher. And prostate. I think that's our BLT kosher pickle. And that covers about 90% or more of the metastases to the jaw. If you want to go on, you can remember rectum and stomach, melanoma. But that pretty much covers the big ones, the more common ones that tend to metastasize to the jaws. Actually happens more commonly in females, likely because breast is so common. Breast cancer, 31% of all metastases to the jaw. As expected, as with any malignancy, it'll cause pain and paresthesia. Can tend to destroy the hard palate, invade the PDL space, as I've shown with other malignancies before. In some cases, they aggregate at the apices of teeth and can mimic periapical radiolucencies. A lot of times, metastatic tumors are well-defined, but non-corticated. So I think of your typical punched out appearance, your typical multiple myeloma, which is going to be really similar to a metastasis. And these two are the ones to remember as ones that can stimulate bone formation, so they can appear radiopaque. So if it's radiopaque and ill-defined, and that's another lecture that I'll get to in a little bit, with ill-defined radiopaque lesions. Mostly we're focusing on ill-defined radiolucent lesions. But while we're talking about metastases, you should know breast and prostate. So the two gender-specific ones, those are the two that cause opacities as they metastasize into the jaws and other areas. So patchy sclerosis, sometimes the spindle, the sun ray periosteo reaction can be caused by these as well. All right, so if you see something worrisome like this, where it looks like it could be metastatic tumor, specifically if you have a multifocal type of lesion, usually you're not going to get your first primary malignancy appear in two sides of the jaw at once, right? And so if you see that and it has malignant appearances, you're going to start thinking metastases. If the primary is known, usually it's pretty straightforward, particularly if you have a radiopaque one. What's it going to be? Well, if it's a male, it's going to be prostate metastasis, female going to be breast cancer metastasis. All right, on to non-Hodgkin lymphoma. I've shown this image to a lot of students, and a lot of them argue, well, it looks well defined, so I want to say it's a well defined thing. But look for these little ragged remnants of trabeculation behind. Also look how it's extending into the marrow spaces. It's kind of widening some of these marrow spaces. It's more invasive than just being isolated to this one part of it that looks well defined. And it looks well defined because that's the area where it's completely eaten through and through the buccal and lingual cortices. But that ragged appearance, eating into the bone, this is not normal marrow space here. This is the same image, the same patient, but a panoramic radiograph. You can see how it's extended back, probably reaching around the root of this tooth as well. The floor of the maxillary sinus is somewhat attenuated, meaning somewhat more radiolucent than it would appear normally. And so this is a pretty extensive lesion. Can I tell specifically that this is non-Hodgkin lymphoma? No. Some of the signs that speak to me as a radiologist is that increased marrow space. That to me looks more like a hematopoietic thing. So those are the ones that really tend to invade the marrow space like that. But I couldn't rule out things like a fibrosarcoma, even an intraosseous, although I said it was rare, intraosseous squamous cell carcinoma. Here, this one, the posterior periapical of the same case. Really see how it's invading, kind of eating into those marrow spaces, leaving behind these spindulations of the trabeculae. And it is extending all the way back here to the root of that tooth. Look for it to invade the PDL spaces. Lymphoma, any of these malignancies that we've talked about can do that. This is one that can occur, typically occurs in older patients. In the next slide, I'm going to talk a little bit more about age and why it is that we expect lymphoma to just be in older patients, even though there's certain types of lymphoma that younger patients can get. Okay, this image is a great one for showing that it's invading those PDL spaces around the roots of these teeth. You get that little PDL space halo around the roots of the teeth, especially when you don't suspect a periapical inflammatory lesion. It doesn't look like your typical periapical radiolucency. You know, it's more involved around the sides of the teeth and more just that irregular destruction of the PDL space pattern, which should be a strong indicator of a malignancy. Then down here in some periapical radiographs, we see that same sign, this kind of ill-defined lucency around the apices of the teeth. As far as I can tell, no caries, no fracture, nothing making me think this tooth should have a periapical inflammatory lesion. Especially in the anterior mandible, you might be thinking, what, cemento-osseous dysplasia? But it doesn't really look like that either. Cemento-osseous dysplasia tends to stay isolated just to the apices of the teeth, just like a periapical inflammatory lesion. And so this is more of a sign of malignancy. All these are non-Hodgkin lymphoma. This is one of the 3 L's that I'll mention in the Principles of Interpretation lectures, one of the 3 L's that can tend to displace teeth occlusally. And so displacing structures, typically you're going to think of that as more of a benign sign, something that, especially if it displaces canals, maintains the cortical border around it, pushes teeth around. Most often you think something more benign, but this last point here, this last bullet, is the exception to that rule. If something is displacing a tooth occlusally, That means it's developing at the apices of the teeth. And really, it's only malignancies that tend to do that. And specifically, these 3L malignancies, lymphoma, like we're talking about right now, leukemia, typically in younger patients, developing teeth, and Langerhans cell histiocytosis, that really tends to develop around the roots of the teeth. Okay, here's the slide where I talk about lymphoma, age distribution, why it is that we only see, radiographically, we only expect to see lymphoma effects in older patients. So let's start with Hodgkin lymphoma. It's kind of bimodal in distribution, can really affect any age. You see even down to the age of 10, in the teens, early 20s, it's pretty high. But Hodgkin lymphoma is more of just a lymph node disease, more of a soft tissue disease. It doesn't tend to spread to other tissues. Rarely is it ever going to spread into bone. And so you're not really going to see Hodgkin lymphoma as a sign in oral radiology. On the other hand, non-Hodgkin lymphoma, 2 to 8 times more common, and it does metastasize into the bone, and it will metastasize into the jaws. It can metastasize around the teeth, as we just showed on the previous slides. And non-Hodgkin lymphoma, look at the age distribution, going to be really rare, even in the teens, but especially under 10. And so lymphoma, I'm typically thinking more of an older age patient population, and that tends to be what you see. Oh, here's an exception to that. Although this is pretty rare, especially in America. Burkitt's lymphoma used to be considered endemic to Africa. And this is a very, very aggressive, very rapidly spreading, or rapidly expanding malignancy. In fact, this is probably the most rapidly expanding lesion someone can get. And so if a lesion doubles in less than 24 hours, probably going to be Burkitt's lymphoma. All right, we said lymphoma can tend to develop around the roots of teeth, and that's what we see here. It looks somewhat well defined, but if you see this, the patient's probably aware because it's pushing the teeth around. It's expanding that rapidly, in less than 24 hours. So very different than even your typical infection, any other type of lesion. But gratefully, this is somewhat rare. Might want to differentiate from other types of sarcoma. Ewing sarcoma can be fairly expansile. Osteosarcoma can be pretty expansile. Cherubism, that's pretty different to me, cherubism. I think I've talked about that. If not, I will talk about it in multifocal lecture. Non-Hodgkin, older age group, as we just mentioned. All right, leukemia. This is another one of the L's that tends to push teeth outside of the socket or push teeth occlusally, as we see in this panoramic radiograph here. Should this tooth be erupting already? Clinically, this should raise some serious red flags. You've got a second molar. This is the primary second molar. They just don't have a premolar developing underneath it. And so this is the first molar. This patient's only about 6 years old, as this first molar is just starting to erupt. And the second molar, which is just starting to calcify, the crown, the cusp tips are just starting to calcify, and it looks like it's erupting. And so you've got this well-defined lesion. Would you expect a periapical inflammatory lesion here on this tooth? Hopefully you recognize that and say, no, this shouldn't be even exposed to the oral environment. Way too early to get caries in this teeth. Something is causing this to erupt. Clinically, you might look at this. It might be mobile, and as you press on it, you might see blood coming out from around the sulcus. Very bad sign that this could be a leukemia. All right, this one, like Hodgkin lymphoma, is bimodal distribution, can affect the very young or the old. As with many of these, especially the hematopoietic malignancies, can make the patient feel very unwell, cause bone pain. All right, these ones are not developing around the roots of developing teeth. So the patient's a little bit older, but you see it's still around that level, and it loves to invade PDL spaces. Do you suspect an inflammatory lesion just looking at that? Maybe if your eyes are just isolated on that one spot and you don't look at the rest of the image, but something's going on around here. Something is widening here. I said this was maybe a sign of, I compared it in that previous radiograph of lymphoma, that expanding marrow space. That's a strong sign of a hematopoietic malignancy. And so lymphoma or leukemia is another one. Another sign of it spreading along the PDL space in that tooth, that kind of ill-defined halo around the root of the tooth that isn't a standard periapical lesion, nothing going on in the crown of the tooth. A lot of signs point towards something more rare, something more severe going on in this case. So those are leukemia. All right, leukemia, it is a serious disease, affecting these young kids. They'll probably feel very sick. Usually it's diagnosed before radiologic signs, but you may see a case like that previous panoramic where it develops in the apices of teeth. How would you differentiate from lymphoma based on what I just told you? Lymphoma, you're not going to see in kids. So leukemia is going to be a lot more common in kids, especially something you're diagnosing radiographically. In fact, that's what I'm talking about, because kids can have lymphoma, but they have which one? They have the Hodgkin lymphoma, which doesn't metastasize to the jaws. It's not going to appear radiographically. Other types of metabolic disorders. So another lecture I have is going to talk about metabolic and endocrine disorders, things that are more generalized, and they tend to cause a generalized appearance, change of bone. And so leukemia is a little bit more isolated, but I guess those could appear similar. And these ones are pretty rare, so I guess you just be familiar with them. There are malignant varieties of ameloblastoma. So malignant ameloblastoma and ameloblastomic carcinoma. The difference between those is histology. Histology, the malignant ameloblastoma actually appears benign, but it metastasizes, whereas ameloblastic carcinoma, it's got carcinoma in its name. Everything about that is malignant. And so histologically, it appears malignant as well as it metastasizes. So both these are accepted as malignancies because of that. That's like the main distinguisher between if something is malignant or not, whether or not it metastasizes. And clinically, they may appear similar to ameloblastoma. You see, it does kind of have that soap bubble shape, somewhat well-defined smooth borders, but at the same time, it looks a little bit more destructive. And so start thinking of one of these if you see something that looks like ameloblastoma, but maybe it's starting to have a few signs of malignancy or has ragged borders, it's destructive, leaving these teeth floating in air. Could it just be an infected ameloblastoma? Yeah, anything benign can get infected and have somewhat ragged or ill-defined borders. But basically all the borders look like this, and it looks a little more aggressive, I would say, as far as destroying the bone compared to your typical ameloblastoma. And this is another one I would have on the differential when you suspect a malignant ameloblastoma. And that's central mucoepidermoid carcinoma, because that can appear very soap bubble. It can appear a lot like an ameloblastoma. It can really stimulate the appearance of one of these benign lesions. See how it looks soap bubble? Even has these well-defined corticated borders, especially this one right here, this coronal slice, expanding underneath the nasal cavity into the maxillary sinus. Very well-defined corticated borders. Everything about that shouts ameloblastoma. Luckily, this one is rare as well. This is what I refer to as the keep you humble lesion. Basically just saying you never really know. Maybe if we look through the entire volume here, we'd see signs of more of those ragged borders, just like I was talking about on the previous slide, where something hints you in the direction that it's more malignant or more aggressive than your typical benign tumor. But just based on this, everything about these looks more like something benign. So keep that in mind. You see a lesion like this, you suspect probably under differential for these ones, just based on what we see here. It's going to be your ameloblastoma, your OKC, and you might not be thinking malignancy. And then that's why biopsy is always important. Biopsy could come back and point out it's one of these rare malignancies that's simulating a benign thing. So see the well-defined corticated borders. But again, this is pretty rare, so I don't always have this high on my radar unless I look at something and the first impression is ameloblastoma, and I look closer at the borders and I see them somewhat ragged, and I might be concerned. I'm thinking one of those malignant varieties of ameloblastoma, or I'm thinking maybe central mucoepidermoid carcinoma. All right, for the next few minutes, if you're interested, I'm going to go through a few cases. I'll give you a second to look at them. Maybe pause the video on the slides when you see them and see if you can come up with a diagnosis, and then I'll discuss them briefly. So take a look at this one, pause the slide. You've seen this before, and hopefully you can identify right away where the problem is. You see these teeth floating in air. When I look at a panel, my eyes are just drawn to the sinus borders, just because I'm used to doing that. I'm used to looking at the anatomy. I look up at the top first, kind of divide it into thirds, and I look at the anatomy up here. If you can see the orbits, which we don't in this case, I look at the orbits. And so right away when I see something like this, a panel like this, it stands out to me. This sinus border is missing. This has ragged borders, something ragged and destructive. This is a malignancy. This is one of those cases of squamous cell carcinoma arising from the sinus. Is there a problem here because this is all blurry? No, that's more of a panoramic geometric phenomenon where these aren't in the focal trough. Maybe they had a heavy overbite and the mandibular teeth are class 2 occlusion. They're back pretty far because they look spread out wide and blurred. And so that's more a matter of geometry than it is some lesion here. That's where the real problem is. All right, which one was this one? We just showed this a couple slides ago, so hopefully you remember. It looks very soap bubble, very well defined. But hey, this is not the well-defined multilocular lecture. This is the malignancy lecture. So although everything about this looks like ameloblastoma, this was your central mucoepidermoid carcinoma. So the one of the few malignancies that really mimic a benign lesion radiographically. So always have that on your radar. All right, how about this one? You see the borders destroyed, the sinus borders. It's nice and strong here, well defined. It starts to get a bit attenuated, very sparse here. And the bone as well. This is not normal bone. Here it looks well defined, but it's not a smooth border, it's ragged. And if you look at this bone here, it is extending all the way back here. So I can't look at this and immediately say exactly what type of lesion it is. This could be a squamous cell carcinoma from the sinus, but this is a lymphoma. It is an older patient. Maybe that's something that could clue you in, although carcinoma is going to be more common in older patients as well. But we said our non-Hodgkin lymphoma was the one that can affect the jaws, that can appear radiographically. And so non-Hodgkin is one that we're going to see in our radiographs. And that one affects more commonly elderly patients, very uncommon in young patients. Take a second to diagnose this one. Give your differential. Is this a malignancy? We see kind of the same pattern all over the mouth. Teeth floating in air. Is that a sign of malignancy? Well, look at the borders. It does have nice smooth borders. A little bit sclerotic here. This one, same thing. We have these molars floating in air, but it has nice smooth borders. The fact that we just see periodontal bone loss everywhere, you know there is periodontal bone loss going on. And yeah, in some of these cases, it's just perioendo lesion. Because the periodontal bone loss is so severe, we see large amounts of calculus around the teeth. Here's a tooth floating in air, completely come loose. Here, I wish I could get paid to extract these ones. Just go in and pluck them out. And so this is just a chronic periodontitis, just a very severe periodontitis that's completely destroyed the bone around these teeth. All right, what about this one? Probably getting a little bit ahead of myself with this case because I talk about this one more in the multifocal lecture, but I did mention this as one of the 3 L's. This is Langerhans cell histiocytosis. And how do we distinguish that from the previous case? Does that look just like a typical periodontitis? What's different about it? Maybe you'll appreciate this scooped out appearance. Periodontitis does not do that. It doesn't undercut the alveolar crest. Go back to that previous case. I can't do it now, but if you go back to that previous case and compare it, the chronic periodontitis, it comes from the periodontal attachment, and it doesn't have this underlying scooped out appearance is what we call it. So that's one of those key radiographic signs, the scooped out appearance. Strong indicator of Langerhans, although it could be a metastasis, but it is an indicator of something much more severe than your typical periodontitis. And also they don't have as severe periodontitis in many of these areas. Another scooped out appearance on this side, very destructive through here. You know, even with severe periodontitis, you don't expect to see this amount of bone destruction. So bad sign. And Langerhans cell histiocytosis is one of the ones that I say to remember develops around the roots of the teeth. And what about this? Same or different as that previous case? Is it scooped out? Yeah. Is that just from a periapical lesion? No, and Langerhans can occur more at the midroot level, although a lot of times it does look like it's at the apices. Some of this does look like it could be florid seminoosseous dysplasia, but here it eats through all the alveolar bone. Here it even extends back into the ramus. Very extensive destruction. So that was another case of Langerhans cell histiocytosis. All right, that's it for this lecture. I hope you feel like you learned something and you can distinguish ill-defined radiolucent lesions and hopefully start to recognize if a patient might have a malignancy, when these red flags should go off in your head. All right, thanks a lot. We'll see you later.